Hi, thanks everyone for logging in tonight to our virtual seminar. My name is Dr. Chris Swanson. I'm an orthopedic surgeon at Southeast Orthopedic Specialists. For those who I haven't met before, I specialize in sports medicine and do shoulder and knee surgeries and see patients with shoulder and knee pain of all different ages. Tonight, we're going to talk about shoulder arthritis, from resurfacing to reverse replacements. And we're going to try to give an overview of shoulder arthritis and then talk about the different treatment options that there are, and specifically focus on the surgical options that are available to people who are having pain from shoulder arthritis that just isn't responding to typical conservative treatments. And then at the end of the talk, after we go through everything, there'll be an opportunity to ask questions if you have any that come up during that time. So the shoulder is a complicated joint. The shoulder has the most mobility of really any joint in our body. It's what allows us to do everything that we do throughout the course of a day, from getting dressed in the morning to reaching into the back seat of the car to putting things on the top shelf. All the mobility that's present in that shoulder is what allows us to do all those things and to put our hand in any position in space, which is incredibly important for the tasks that we perform on a given day. And so on the left side of the screen, you can see that the shoulder is a ball and socket joint. The ball portion is called the humeral head, and the socket is the glenoid. And that'll be important as we see some X-rays and MRIs, and refer to that later in the talk when we're talking in more detail about shoulder replacements. There's also a small joint above the ball and socket joint called the acromioclavicular or AC joint. You can also get arthritis in the AC joint, although this typically isn't as substantial of a problem. It's not typically as painful. Most often doesn't need surgical intervention. And this is not a joint that is ever replaced. If you do have a problem with your AC joint, sometimes you remove a small portion of the end of the collarbone. The picture on the right shows the rotator cuff muscles. The rotator cuff, we hear about a tremendous amount of people who have problems with their rotator cuff, from tendonitis and bursitis to partial tears, to sometimes complete tears of the rotator cuff. And the rotator cuff muscles are important for all the mobility and motion that I just spoke about. And again, because of that mobility in the shoulder, the integrity of the rotator cuff is important not only for normal function of the shoulder, but also it's very important in deciding what you may need to have done if you have enough arthritis in your shoulder that you're thinking about having a shoulder replacement. And so there's four main muscles of the rotator cuff. The subscapularis is the muscle in the front. The supraspinatus, which is the most commonly injured muscle and which helps us to raise our arm above shoulder height, is the muscle at the top of the shoulder. And then the back of the shoulder, you have the infraspinatus and the teres minor. And so the combination of the muscle and the bony anatomy of the shoulder is what makes it such a complicated joint. It's what leads to so many injuries, but also what lets us do so many things throughout the course of our days. So shoulder arthritis. Arthritis in general is a condition that destroys the articular cartilage, or the smooth lining of the joint. All the joints in our body have articular cartilage, which is kind of shiny white cartilage. It's almost like a cue ball. And when we start to get wear in our joints or arthritis, this cartilage starts to become damaged and diseased. And eventually you start to lose that articular cartilage over a period of time. We've heard people talk about bone-on-bone arthritis, and when we talk about bone-on-bone arthritis, it means that both sides of the joint have lost all of that smooth lining and all of that articular cartilage. The symptoms of having arthritis in our shoulders start with pain. That's the primary symptom that most people will complain of if they have arthritis in their shoulder. Once you've had arthritis for an extended period of time, especially if you start to develop some bone spurs from that arthritis, it can begin to limit your range of motion. You can also have crepitus, which is crunching or clicking and popping that you feel when you rotate or move your shoulder. And over an extended period of time, often due to the pain or the limitations with the motion, you can develop weakness in the shoulder. And you can even have weakness in the shoulder if your rotator cuff is intact. That can just be related to the response to the pain that you're having in the shoulder. Now, the good news about shoulder arthritis is that, because we don't walk on our arms like we do on our legs, we can tend to tolerate even very severe arthritis in our shoulder for a much longer period of time than we can in our hips and knees. The weight-bearing joints like our hips and knees, which bear our body weight every day, often become more symptomatic with less severe arthritis. So even sometimes tremendously severe arthritis in our shoulder can be tolerated by people and can respond fairly well to conservative management. So treatment options for arthritis, just like most things in orthopedic surgery, always start with conservative things. And so if you have arthritis in your shoulder or pain in your shoulder and you're evaluated in the clinic, most often we start with an X-ray, and an X-ray will show whether or not you have substantial arthritis in your shoulder. And if you have substantial arthritis that's contributing to your pain and symptoms, then oftentimes the first place to start is with activity modification. So changing some of the things that you're doing throughout the day, using your opposite arm a little bit more than the one that's painful can sometimes help to decrease some of those symptoms. Anti-inflammatory medicines can help, whether it's over-the-counter anti-inflammatory medicines like Advil, Aleve, ibuprofen, Motrin, or prescription strength anti-inflammatory medicines like meloxicam or diclofenac. Those are all strong, potent anti-inflammatories. By decreasing the inflammation in the cartilage and the lining of the joint, a lot of times you can calm down those symptoms and improve the pain that you may be feeling from the arthritis. The next step up from that gets into injections, and the most common injection for arthritis, whether it's in your hip or your knee, and in this case in your shoulder, is a cortisone or steroid injection. This is even a stronger anti-inflammatory. The benefit to cortisone injections really in any joint, but in the shoulder specifically, is that it takes a strong, potent anti-inflammatory and puts all of that medication in the area where the problem is. And now all the injections that we do are under ultrasound guidance, meaning that the ultrasound will go on your shoulder, just like the picture on the right, which allows us to see not only the rotator cuff, but it allows us to see into the shoulder joint. And in the scenario of arthritis, oftentimes because you've lost a lot of space in that shoulder joint, it can be difficult to get the needle into the proper position. This allows us to see it in real time and ensure that that medication is getting exactly where we want it. The other benefit to injections is that you don't really get any systemic side effects from the steroid injection into your joint. If you take a lot of oral anti-inflammatories or oral steroids, there's side effects on your stomach, your kidneys, sometimes your heart if you take them for a long enough period of time. And so an injection into that joint is a stronger anti-inflammatory, and it goes right where the problem is. Following the anti-inflammatories, physical therapy is often ordered. Therapy works on reconditioning and strengthening those rotator cuff muscles that we showed on the previous slide. By doing that, we can improve the position of the ball or the humeral head within the socket, which can alleviate some of that pressure from the arthritic changes in the joint and from the bone spurs. And these are typically the things that you're going to try initially to see if you can get symptomatic relief. And again, oftentimes some of these simple treatments can do very well and can improve your symptoms, allow you to return to activities. If these things are unsuccessful, then that's the time when you want to consider surgery. So how do I decide if all these conservative treatments that we just discussed have not worked, and the pain is keeping me up at night and it's limiting me from golf and tennis and the activities that I like to do, and I can't work in the yard anymore? Then how do I decide what type of shoulder replacement is right for me? And that's a really important question because there's a number of different options that are available, and it depends on it's really patient specific, depends on the symptoms that you're having, depends on the integrity of your rotator cuff. And so there's a number of factors that have to go into deciding what the appropriate type of shoulder replacement is, so that each patient can have the best possible outcome and the highest chance of returning to the activities that they enjoy. So we're going to go through some of these different options. The factors that we have to consider in terms of choosing the most appropriate replacement, initially it starts with age. Along with age, it starts with occupation. If someone's working or if they're retired, that's an important thing to incorporate into the decision-making process. What activities someone enjoys, whether it's weightlifting, whether it's playing golf, playing tennis, whether it's working in the yard, all of those different activities are important in choosing the right type of shoulder replacement. And then probably the most important factor of all is the integrity of the rotator cuff. And the rotator cuff, those muscles that control the function of the shoulder, are incredibly important in helping us to decide what type of shoulder replacement is going to be most appropriate. And one of the real keys is that when you're getting ready to have a shoulder replacement, you have to have a recent MRI. And so even if you've had an MRI a year or 2 or 3 before that showed that your rotator cuff was intact and was functioning well, you need to have one that's recent, within the last 6 months, definitely not more than a year, to ensure that that rotator cuff is intact, because that's going to be so incredibly important to a successful outcome from shoulder replacement surgery. So the first option in shoulder replacement surgery that we're going to talk about is something called resurfacing. And a resurfacing is very, very similar to a shoulder replacement. The main difference between a shoulder replacement and a resurfacing is that the shoulder resurfacing does not remove as much bone as a traditional shoulder replacement. It still covers the ball or the humeral head side with metal and the glenoid or the socket side with plastic. And what you can see on the right of the slide right here is a picture of a shoulder resurfacing implant. And really what the resurfacing attempts to do is it's almost like placing a crown on a tooth. You remove any bone spurs and you remove any, which are called osteophytes, you remove those. You remove any rough edges of cartilage by reaming and removing that cartilage, but you remove almost none or very little of the native bone on either the ball side or the socket side. And what that does is it preserves, one, the majority of your bone in the case that you needed anything done in the future. And then 2, it preserves the soft tissue tensioning of the capsule surrounding the shoulder, as well as the rotator cuff, really allowing for optimal improvement from a range of motion standpoint. The implant is also very small. It tends to feel more natural and more normal for patients. And the implant itself is ovoid shape, not a pure circle, which mimics the natural geometry and the natural shape of the humeral head more closely. So here's a picture of an X-ray of a shoulder resurfacing patient. The X-ray is obviously the picture on the left. And so on the left, you can see a picture of that humeral head, which is the ball, and then on to the right is the socket. And at the bottom of the ball, you can see, I'm going to outline it here with my pointer in red. You can see a really large osteophyte. It's almost the size of a golf ball that's kind of developed on the bottom portion of this humeral head here. There's also a small osteophyte at the top. And so if you can't see that, then just at the bottom portion of the humeral head, what that large object is, that's going to prevent range of motion. It's going to contribute to pain. And in the picture on the right, which is a surgical picture of this patient, you can see at the bottom of that ball this extra bone that there is. And that extra bone, again, contributes to pain. It causes clicking, it causes popping, and it limits range of motion, even in the setting of an intact rotator cuff. And so what's important during the resurfacing is to make sure that you remove all that diseased cartilage and all of those osteophytes. And once you've accomplished that, then you put this nice little metal cap onto the remainder of the bone. And from the image that we saw on the first resurfacing slide, again, you can see how small that implant is. It just covers up that area of osteophyte or diseased bone and cartilage that you've removed. And you preserve the remainder of the native bone of the humerus. And then on the glenoid or socket side, you place that small plastic component which is set into the bone. And so now you have metal which is articulating on plastic, but you've really preserved the soft tissue structures. And on the right, you can see the X-ray of this patient, again showing that small metal cap on the humeral head. And so here is a video of this patient at 8 weeks after surgery. Or what we're looking for is to see if he was able to achieve a good range of motion. So he's just about 2 months out from his surgery. And the surgery was on the right shoulder. And so what we can see here is that just at 2 months after surgery, which is still very early in the recovery process from any shoulder surgery, but especially from a replacement type of surgery, he's really achieved almost very close to symmetric range of motion, or the range of motion that he had on his left, on his non-operative side. And from here, at this point, it's only going to continue to improve for him as he continues to get stronger. And so that's a really nice outcome from that shoulder resurfacing procedure. So there's a number of articles that have been published in the orthopedic literature over the past several years that have talked about this resurfacing procedure, which is becoming more and more popular. And so the anatomic total shoulder replacement with an inlay glenoid with a stemless ovoid humeral head. So that's a fancy way of saying the shoulder resurfacing in an active population results in improved clinical outcomes, no reoperations, no radiographic loosening, and a high rate of return to activities at short-term follow-up. And that's really all the things that we're hoping for from a replacement type of surgery, is that we feel better clinically, we don't need another surgery, we're able to return to the activities that we want. A very, very recent study from late in 2021, again, talking about the inlay total shoulder arthroplasty, which is again a fancy way of saying shoulder resurfacing, results in significant functional improvement, pain relief, increased patient satisfaction scores in people with advanced shoulder arthritis, and different glenoid pathology, meaning different shapes of the glenoid or socket. And their results, they argue, provide further support for this new option in shoulder replacement. And again, this is something that we've been using over the last several years, and patients have really liked this procedure. They've been able to return to their activities. They've gotten tremendous improvement in their range of motion function, along with great pain relief. So your traditional total shoulder arthroplasty or total shoulder replacement, this is option number 2. Again, it's very similar to the shoulder resurfacing. It also requires an intact rotator cuff. And so it's also very important to make sure that you have that MRI demonstrating that intact rotator cuff. But your traditional shoulder replacement removes a little bit of more bone from that proximal humerus. And so you actually have to remove or cut some of that bone, similar to what's done in a traditional hip replacement. And then a metal ball is placed onto that humeral side, and a plastic component is placed on the outside of the glenoid or the socket side. And there's a schematic of it on the right of this slide. One of the other big differences with this is a stem, a metal stem, again, similar to a hip replacement, is placed down the center portion of the humerus in the direction towards your elbow. And so some of the advantages to total shoulder replacement, this conventional total shoulder replacement, are that there are modular options to this. And what that means is that there are some implant options that allow for conversion to a reverse shoulder replacement without having to remove all those components. And so there's value in that for somebody who's younger, or for somebody whose rotator cuff may not be perfectly healthy and may need to be switched or converted to a reverse shoulder replacement in the future. There's the possibility of doing that without removing all of these components. And so that's one substantial benefit to a traditional total shoulder replacement. There's also a number of different stem, and now even more recently, some stemless options. There's long stems, short stems, and then the stems seem to be trending in the direction of continuing to get shorter and shorter to preserve as much bone as possible for a number of reasons. One, decreasing the possibility of fracture if you were to have a fall, and then 2, preserving bone in the event that you did need an additional surgery in the future. And so here's an X-ray of one of our patients with shoulder arthritis. This person was in their mid-60s. They'd failed those typical conservative measures, including the cortisone injections, including physical therapy. The X-ray on the left shows loss of the joint space. So that ball or that humeral head is getting closer and closer to the socket. Again, at the bottom portion of the ball, you can see a little extra bone, which is a bone spur. Again, those are painful. They contribute to limitation of range of motion and cause pain as well. The X-ray on the right shows that that ball on the socket is actually sliding backwards, or almost sliding a little bit out of the back portion of the joint. This leads to more arthritis, causes pain and limitations with range of motion as well. And then here's an X-ray. This is this patient's post-operative X-ray after a traditional shoulder replacement. It shows a short stem going into the humerus, and then that metal ball attached to that short stem, and then there's a plastic component attached to the socket side as well. And this is the short stem version of a total shoulder replacement. A longer stem would go further into the bone than that. And then this is finally a picture of my PA Kendra with this patient at a high school football game with that arm pointing straight up in the air, which again is an excellent outcome for someone who is having difficulty getting their arm above shoulder height prior to that surgery. And so the last type of shoulder replacement that we're going to talk about, and one that really has gained more and more prominence in probably the last 10 years, is the reverse shoulder replacement. And so the reverse shoulder replacement is something that's been used in Europe for probably the last 20 to 25 years. It's been used more and more prominently in the United States. In the last 10 to 15 years, there's been a substantial increase in the number of reverse shoulder replacements performed, the variety of options that are available from a reverse shoulder replacement standpoint. The main function of the reverse shoulder replacement is that it allows patients to achieve improvements in range of motion when you don't have a functioning rotator cuff. And so if your rotator cuff is torn and can't be repaired, or has been torn for too long of a period of time, and it's allowed the humeral head to migrate superiorly until it's rubbing on the bone on the top of the shoulder, which is called rotator cuff arthropathy. Previously, 15, 20, 25 years ago, we just did not have a good option for these patients. You could have a partial shoulder replacement, which is called a hemiarthroplasty, and it sometimes helped patients in terms of improving their pain. However, it offered very little improvement in range of motion. And for patients with a massive rotator cuff repair that can't be fixed over time, oftentimes they lose the ability to compensate over a period of years. And some people actually can't raise their arm at all. They're able to bend their elbow and move their fingers, but they can't raise their shoulder at all. And we previously just didn't have a good solution for these patients. But the reverse shoulder replacement has given us an excellent option to restore range of motion for patients who otherwise really struggled. The other use for the reverse shoulder replacement is in complicated fractures. And so as we get a little bit older, if we fall onto our shoulder, sometimes we can break that ball into multiple pieces. As our bone gets a little bit softer as we get a little bit older, there can be a number of pieces, and it can be difficult to get this to heal. And so again, this is another great use of the reverse shoulder replacement, because by actually removing those fragments, replacing it with the reverse shoulder replacement, you can achieve stability with the shoulder, excellent pain relief, and improve your range of motion. The general concept of the reverse shoulder replacement is that the traditional ball and socket is flipped. And so the ball in the replacement goes on the socket side, and the socket goes on the ball side. What that does is it changes the mechanics of the shoulder. And so you no longer rely on your rotator cuff to achieve range of motion of the shoulder once you have a reverse shoulder replacement. Your deltoid muscle, which is the muscle that previously has moved our arm up to the side, our chicken wing muscle, is now used to raise our arm back above shoulder height. So we no longer rely on that rotator cuff, which for the most part, when you're getting a reverse shoulder replacement, is no longer intact. The pain relief that people get from a reverse shoulder replacement is excellent. Most people achieve almost complete pain relief. The one downside to the reverse shoulder replacement is that there is a limit in terms of how much lifting you should do. There's no exact number, but we generally try to keep people from lifting above 25 pounds or so with that arm specifically, just simply because if you were to lift too much, were to put too much weight into that arm, there is a potential that you could dislocate or disassociate that prosthesis, because that socket is now where the ball had previously been, and so it becomes easier for that to dissociate from the ball. And some of the most interesting and kind of the newest technology in the shoulder replacement world is custom-made shoulder replacements. And so what we use in all of our shoulder replacements, we require all of our shoulder patients to obtain a CAT scan of their shoulder. And the importance of the CAT scan is the CAT scan shows the bony detail of the shoulder, the bony anatomy of the shoulder in tremendous detail. And so just looking at the CAT scan, we're able to learn a lot about the wear pattern that a specific patient has in their shoulder. What we're also able to do, and what we've been working with several companies on, is improving the technology and the customization of these shoulder implants. And so that CT scan is taken and uploaded into specific software. The software takes that CT scan and then creates a model. And then we're able to design guides or 3D positioners that are custom specific to each patient. And then this allows us to perform the cuts and the reaming that we need to do and place an implant in a perfect position that's specific to every individual patient. The next step in this technology, which is really exciting, is that in the very near future, we're really going to be able to do this real time. It still will be based off of a CT scan, but we'll have Bluetooth feedback on our drills, on our saws, on the equipment that we're using, that's going to tell us when we're in the perfect position in order to start that process. And that's kind of the really exciting technology that we've just continued to improve on over the past 5 or so years. And the goal is really to make sure that we have an implant that fits perfectly for each individual patient. There really is no one size fits all, especially in shoulder replacement surgery, where the glenoid or socket side of everyone's shoulder is very small. There isn't much real estate to begin with. And so getting that perfect is just incredibly important. And the technology for that continues to improve. And so the next slide is going to show a short video about really just how unique and interesting this platform, which is called SmartSpace, is, and how it really helps us to design a custom implant and a custom guide for each patient. And so again, it all starts with the CT scan. The CT scan is uploaded, creating this model of the shoulder. And here you can see the ribs, and then this is showing the CT scan of the shoulder. And as you move through the CT scan, it lets you then use this model to create a custom guide for both the socket side, and that's showing adjusting of the model on the socket side, and perfect position of the socket. Again, you can relate it back to the CT scan. That's showing the screws actually positioned in the bone, holding that in position. And then now this moves to the humeral side or the ball side, again showing that implant fitting perfectly within that CAT scan, creating this 3D model that shows the tension of the soft tissues, ensuring that you get as close to a perfect implant each time and as you possibly can. And the guides, again, these are the custom guides that are built from that. And so the technology is just really incredible, and it continues to improve, and it continues to allow us to really personalize the implant to each individual, and improves our accuracy. It improves the guidance of the surgery, and then ultimately it improves the outcome because you have components that are fit perfectly to the size, shape, and wear pattern of your individual shoulder. And then again, this is the last slide about that, which these are the individual guides that technology produces for each patient and each person. And so these are specific, they're placed onto your shoulder at the time of the surgery, and they allow us to make sure that the pins and the cuts are performed in the perfect position. So here's an X-ray of a patient. This patient was 77 years old. They had mild to moderate arthritis, which you can see in the X-ray on the left and the right. But what they had was a massive irreparable rotator cuff tear. They'd known they'd had a rotator cuff repair for more than 20 years, and they had never previously had surgery on it. And so when they came into the office, that tear had retracted or pulled away from the bone so substantially that there was no way to reattach it to the bone. And therefore, because they were so limited with their range of motion, their only option became the reverse shoulder replacement. And here's an X-ray of the reverse shoulder replacement. This is using a short stem. There are longer stems, but this is a short stem, which again preserves a little bit more bone, decreases your risk of fracture from a fall. But again, you can see now that the ball, or that circular piece, is on the socket side, and the cup portion of this replacement is on what was previously the ball side. The other example that we talked about for reverse shoulder replacements was fractures. On the left, compared to the X-ray from before, where you can see a nice round ball, you can see on this slide that that ball has been basically completely destroyed. And so this is actually a fractured dislocation of the shoulder with a number of different pieces. And at this point, the arm is basically not connected to the rest of the body. Again, previously, we did not have very good options for this. This would be an incredibly difficult fracture to get to heal, especially in someone in their 60s or 70s or 80s. But the reverse shoulder replacement gives us a tremendously powerful option for this. At the time that this patient was seen in the office, they could not move their shoulder at all. Zero range of motion of their shoulder. Their nerves were working. They were able to bend their elbow, able to move their fingers, but they actually hadn't moved their shoulder in several months. On the right is the post-operative X-ray of their reverse shoulder replacement. Again, note that that ball is now on the socket side, and the cup is now on the side that the ball had previously been, which is the reverse shoulder replacement. And the alignment looks good. The shoulder's nice and stable. Once they've healed from their surgery, they'll have little to no pain anymore from what was previously an incredibly painful injury. And then here's a 3-month post-op X-ray of this patient who previously hadn't been able to move that shoulder at all. And so that's about 90 days after his surgery, really very close to normal range of motion of his shoulder, which is excellent. Again, he'll continue to see improvement in terms of his motion and strength over the course of about an entire year. We do want to limit him to about 20 to 25 pounds of lifting, just so that we make sure that we have no issues with that prosthesis moving forward. And so, kind of in conclusion with shoulder replacements, you know, the saying of if all you have is a hammer, then everything looks like a nail. And so it's important in when you're managing or treating your shoulder arthritis and you're seeing a physician, that they have a number of different options available, and that they work through and talk to you about all those different possibilities, because each situation is really unique. And again, I hope that what you've taken out of this is there's a number of factors that have to go into that decision, from your age and activity level, to what you do for work, to the integrity of your rotator cuff, to how much wear you have of the bone on both the ball side and the socket side. But it's important to have a number of different options that you're comfortable with, so that you can give people the opportunity to choose the one that's going to allow them to not only have pain relief, but return to the activities that they're interested in. Yes, so some of this we touched on a little bit, but the options for treating a rotator cuff tear and treating arthritis are slightly different. The conservative options are sometimes the same, from injections to physical therapy. If you have a rotator cuff tear without substantial arthritis, a lot of times you'll try to treat that arthroscopically, meaning minimally invasively with the camera, where you go in with small incisions around the shoulder, and you try and reattach the rotator cuff back to the bone so that it has a chance to heal. In the setting of a rotator cuff tear with severe arthritis, oftentimes you may move to the reverse shoulder replacement, again, depending on age and activity level. But the treatment options are different for rotator cuff tears and for arthritis. So biologic options are really one of the kind of hot topics, not just in orthopedics, but really in kind of in society in general. You hear advertisements on the radio and on TV about using platelet-rich plasma, which is PRP, to regenerate hair, and you hear it for all different kinds of things. There's a number of good uses for PRP, or platelet-rich plasma, in the shoulder. One of the best studied uses in the shoulder is for partial thickness tears of the rotator cuff, where it can stimulate a healing response and allow the muscle and tendon to heal. There's very good studies for PRP, or platelet-rich plasma, on knee arthritis. There aren't as many studies on shoulder arthritis. Now, certainly PRP, because it comes from a patient's own blood and it has their body's best growth, healing, and anti-inflammatory factors, is not harmful in any way. There aren't as many good studies on shoulder arthritis specifically, but there's a number of really good studies on knee arthritis. We specifically, my team has used PRP for both partial thickness rotator cuff tears and for shoulder arthritis. And empirically, we've seen good symptomatic relief for both of those patients. Again, part of the importance being making sure that when that's injected into those places, whether it's the rotator cuff, whether it's into the joint for arthritis, or both, utilizing some guidance from an ultrasound machine to make sure you're getting it into that proper position is very important. So maintaining range of motion of the shoulder is very important. An incredibly painful shoulder condition is frozen shoulder adhesive capsulitis, which means inflammation in the capsule. The best way to prevent adhesive capsulitis or prevent your shoulder from becoming stiff is by using your shoulder, by working on stretching and strengthening exercises, using bands and light weights to perform a daily stretching and strengthening regimen is the best way to prevent your shoulder from getting stiff. One of the other problems is oftentimes patients are placed into a sling. If you injure your shoulder and you go to the emergency room or to urgent care, a lot of times doctors or nurse practitioners or PAs in those settings will just place a patient into a sling. If you wear a sling for too long with your shoulder kind of locked in that position across your body, it tremendously increases your chances of becoming stiff. And so it's important not to wear a sling too long in most of those settings unless you have a really severe shoulder fracture. No, a partially or completely torn rotator cuff does not prevent replacement options, but it is really an important part of that decision-making process. And so sometimes in a younger patient, you'll actually repair the rotator cuff first and give the rotator cuff a chance to heal completely, and then come back 6 to 9 to 12 months later and do either a shoulder resurfacing or a traditional total shoulder replacement. And the opposite holds true, that sometimes in an older patient in their 80s, sometimes even in their early 90s, if they have a substantial rotator cuff tear with arthritis, then you move towards the reverse shoulder replacement instead of repairing the rotator cuff first. And again, the nice part about that new technology and the reverse shoulder replacement is that's really meant for people oftentimes in their late 60s, 70s, 80s, sometimes even 90s. We've done one on the oldest patient that we've done on was a 94-year-old gentleman, and he just did excellent with it. He was motivated and was able to really regain tremendous range of motion. So it really is not an age-based option. It's something that remains an option almost no matter how old you are. So again, the resurfacing and the reverse replacement are kind of on completely different ends of the spectrum. So the resurfacing means that you have an intact rotator cuff, a rotator cuff that's quite functional and that your muscles are really working very well. And so the expectation from a resurfacing with an intact rotator cuff is really that you can get back to any activity, whether it's lifting weights, playing tennis, playing golf, really any high impact activity that you want to return to. The amount of time it takes to get back to that is going to be slightly different for everybody. Most people are starting to kind of ease their way back into those types of activities somewhere between 3 and 4 months after surgery. By 6 months, certainly I'd expect anyone after resurfacing to be able to do just about anything that they wanted to do. The reverse shoulder replacement, again, means that your rotator cuff really wasn't functional. And so now we're relying on our deltoid to perform more of that range of motion. You can get back to playing tennis. You probably aren't going to be able to play quite as aggressively as you may have before. And again, there is that kind of weight limit of around 25 pounds or so. And it's going to take longer to get your motion back to a level where you can play tennis. And from a tennis specific standpoint, the thing that's going to be the most difficult is overhead serving, and kind of any overhead volleying, those type of overhead things. Ground strokes, forehand, backhand are something that's going to be a lot easier to return to more quickly. The therapy and kind of the recovery process for both of the surgeries, is pretty similar, especially initially. So both of these surgeries take between an hour and a half and 2 hours. They both can be done on an outpatient basis. The only time these days where anyone stays in the hospital is if they're limited in terms of their help at home and don't have anyone who can help them in that kind of day or two after surgery. Otherwise, almost all patients who have either a resurfacing, a traditional shoulder replacement, or a reverse replacement go home the same day. After surgery or in a sling, you wear the sling for about 1 month, regardless of which type of replacement that you just had. The physical therapy generally starts about 10 to 14 days after surgery. And the first month or two are spent really working on restoring range of motion. Once you restored range of motion, then we transition to focusing more on regaining strength. It usually takes another couple of months to really regain our strength. So the total duration of physical therapy, again, it's very patient specific. The first couple months, everybody needs. From there, it becomes a question of how quick you can regain your strength. Usually most people have transitioned out of therapy to doing exercises just on their own at home or at a gym between 3 to 4 months after surgery. So pain in the deltoid, so the deltoid muscle is the primary abductor of our shoulder, meaning it raises our arm out to the side. And so pain in that muscle can be from overuse. It can mean that you're having a problem with your rotator cuff, whether it's tendonitis or bursitis of your rotator cuff, or a partial or complete tear of your rotator cuff. Because in the setting of rotator cuff disease, then we start to rely on our deltoid to help us to raise our arm overhead to allow us to do the things that we do throughout the course of our day. And so if you're having pain in your deltoid, it can mean that you're compensating. And when we compensate for shoulder pain, we overuse our deltoid and our trap. It sometimes causes spasm in these muscles. We can feel it almost on the side of our neck. It can sometimes lead to headaches. And so shoulder pain can really masquerade as neck pain as a result of that. Yes, so rotator cuff tears. So the majority of rotator cuff tears start out as small tears or partial tears. And over time, initially patients are able to compensate by using their deltoid and their trapezius muscles to make their arms appear like they're functioning normally. And over time, small tears throughout the course of our lives with all the activities that we do can enlarge and can become bigger tears. And that's really the natural course of rotator cuff tears, is they tend to slowly enlarge over time until they've gotten big enough that the symptoms really become substantial and we really start to lose more of our strength and more of our mobility. So the answer is yes, especially if you have a complete tear. A small complete tear over time is likely to become a larger complete tear.